So for type 2 diabetes, I'm going to be mentioning the pathophysiology, the diagnostic tests, the medications, the clinical manifestations, and then lastly the risk factors. For multiple reasons, the blood glucose concentration tends to be uncontrolled. And the ultimate, I guess, problem with this is that it usually tends to be a form of chronic hyperglycemia. And just for a reference of what the normal glucose concentration is, yeah, I've read different things out there, but most of them tend to be in or around plus or minus 5, 120 to 70 milligrams per deciliter. There's really two good reasons to explain why someone develops type 2 diabetes in terms of a pathophysiological mechanism. The first one is insulin resistance, and then the second one is beta cell dysfunction. And in insulin resistance, what's happening is a lot of the key regulators, or I don't want to say key regulators, I guess I want to say a lot of the key players in terms of your systemic glucose metabolism, your muscle cells, your liver cells, your adipose cells, your fat cells, these guys do not respond to insulin for a long series of events that I'm not really going to go into. Insulin binds to these cells and binds to its receptor site, and through a very, very long signal transduction pathway results in transcription and then ultimately translation of a glucose transporter protein. The GLUT is not a good mnemonic for it. It stands for glucose utilization transporter. Basically, it's just a protein for passive transport of glucose to flow into the cells from high concentration to low. And in insulin resistance, these cells do not respond to insulin because of many, many steps in that pathway. But the other thing that's happening as well, and I should have probably clarified that this is a insulin resistance or beta cell dysfunction. But when beta cell dysfunction, what's happened is, for one reason or another, the beta cells of the pancreas, the cells that actually produce the insulin, have been damaged and they're no longer functional. Usually this is an autoimmune disease or an autoimmune condition, but also things like oxidative stress can both cause beta cell damage and then also cause autoimmune dysfunction as well. For glucose, though, what's interesting to me is in the free form, and in just the regular glucose, not phosphorylated form, it's a reducing sugar, just like all monosaccharides. And what reducing sugars do really well is they do redox reactions. So, pick up a piece of paper, put a lighter underneath it, burn that piece of paper. That's basically what glucose does inside of your cell. It undergoes a redox reaction. And the problem is when you have a lot of this stuff going around, it's going to start doing redox reactions at really non-specific locations, okay? One of the diagnostic tests for what we're about to find out is a redox reaction at the hemoglobin, at the protein. Another thing that's also bad about this is that glucose, just like any solute, can affect the tonicity of something, and this can in turn result in a lot of excess fluid building up in the interstitial space, which has a lot of symptoms we'll talk about later on. So for the first diagnostic test, it's called an A1C, and what we're doing is, if we were to go back here, when I mentioned that glucose being a reducing sugar, yeah, we're checking for that. We're checking to see if glucose has reached a high enough concentration to where it's starting to really glycosylate a lot of hemoglobin molecules in your blood. And the reason why this is really good is this can provide about the average blood glucose levels within the past few months. So this is usually the first test that they're going to run if a doctor suspects diabetes. It's nice also in that it's just one blood draw per test, and you don't have to get stuck multiple times over and over and over again. It's considered a positive diagnosis if on two separate tests, just to be safe, that these are at least 6.5% or higher. Usually, though, it's a normal value if it's 5.7% or lower. So anything between 6.5 and 5.7, that would mean that you are at risk for diabetes, but you don't actually have diabetes unless it is 6.5% or higher. The other one that we'll do is called a fasting blood glucose test. And this gives us a positive diagnosis, again, on two separate tests if they are above 122 milligrams per deciliter. And then another form of that, which is it's a form of a fasting blood glucose test, but in this case we're doing it through oral administration of glucose. And we see how the body responds to this massive influx of sugar, okay? And so it's considered positive if the person's blood glucose level is above or equal to 200 milligrams per deciliter, and it's considered normal if it's 140 milligrams per deciliter or lower. And just like in the previous one, if you're anywhere in the value in between that, that puts you at risk for diabetes, but you're not actually going to be diagnosed with it until you have above 200 milligrams per deciliter. The last one that we can use is a random glucose test as well, where we do just that. We randomly will test someone's blood glucose, and if it's above 200 milligrams per deciliter, that generally tends to yield a positive diagnosis. I don't really like this because obviously the values are going to fluctuate quite a bit depending on what those times are, if it's random before or after eating. So you need to kind of, I guess, take into account things like patient history, when they ate, and all of that stuff, but that is one of the tests that we can do. So there's lots of symptoms and then problems that can arise when you have this condition. Frequent infections tends to be one of the most earliest indicators, and you have an increased concentration of glucose throughout your body. That's going to lead to an increased amount of microbial growth throughout the body as well. It tends to often manifest itself in the skin for reasons that don't quite make a whole lot of sense to me, but usually I guess because of that's an area with a lot of microflora, I guess would be the best I guess, hypothetical explanation for it. There's also tends to be an increased amount of weight loss, fatigue, and hunger. This is because if you don't have glucose inside of your cells, you're not going to be able to make ATP through that. You're going to start using secondary biochemical pathways to do so, breaking down fat, breaking down muscle to ultimately produce ATP. There are also going to be a lot of frequent urination and then blurred vision. Because glucose can affect the tonicity of something, it's going to result in a lot of fluid leaving the cells into the interstitial space, which is ultimately going to be excreted through the kidneys. And then also the blurred vision, because that tonicity can also affect the, I think it's called the vitreous humor, the fluid inside of the eye that helps keep things stable and maintains homeostasis there. Some of the complications, though, that can arise from this are not just because of what we talked about at the top, but also really to tie itself back to the pathophysiology, mostly about glucose being a reducing sugar. So we're going to have neuropathy, nephropathy, so we're going to damage the nerves, we're going to damage the kidneys, we're going to start having atherosclerosis, hardening of the arteries, very slow healing wounds, and all of this stuff is because of damage done to the blood vessel endothelium, which is the whole part of that whole glucose being a reducing sugar, and then many other parts of the pathophysiology that I had previously mentioned. What I found really interesting to me is that people who have type 2 diabetes are more likely to develop Alzheimer's disease. Now, this is just a correlative relationship. There's no specific mechanism that's given. I assume that if you have an excess amount of redox reactions going on inside your body, that you're going to be under more oxidative stress and therefore more likely to develop Alzheimer's disease. But that's just a hypothetical situation. There's no actual experiments that have been done to prove that that's actually what's going on. So the treatment for it usually tends to be diet and exercise, and then if that diet and exercise tends to fail, they'll start to use medications. So the most common medications are these, and there are also similar kind of variants of them, known as metformin, sulfonylureases, and then they're also starting to use insulin therapy, which I thought was very interesting. Metformin and then all the other drugs that act by a similar mechanism to that, these increase the insulin response and actually will decrease gluconeogenesis at the liver. So we're going to become more responsive to insulin, and we're going to make less glucose at the liver. Sulfonylureases and then other similar drugs that work by a similar mechanism to this stimulates beta cells to increase the amount of insulin in the blood. So basically what we're doing is we're trying to medicinally treat insulin resistance, and we're also trying to medicinally treat the beta cell dysfunction. But what's interesting to me is because, you know, for all the complications that I just listed, if you have a lot of blood sugar going on, that's really, really bad for your body. That's going to cause a lot of health problems. And more often than not, they're starting to kind of change their attitudes about insulin therapy. And now they're starting to use insulin therapy much, much sooner for type 2 diabetes because it controls the blood glucose levels so effectively, far more effectively than metformin or sulfonylureases do. Let's talk about the risk factors. If you're overweight and or you have a sedentary lifestyle, that's a risk factor. You're already going to have a decreased insulin response from that. What's interesting to me is fat distribution, mostly at the hips and the thighs. And I don't really know off the top of my head if this is just a statistical correlation or if there is a causative relationship with that fat distribution, which certainly would make sense in terms of the areas of the body where insulin where we have a decreased insulin sensitivity to, but I don't really know that off the top of my head. For races, I don't really understand this. Asians, blacks, and Hispanics tend to be more likely to get this. I don't think that this is a causative thing. I think that this is a correlative thing, mostly with the blacks and Hispanics, because those tend to be, unfortunately, of lower socioeconomic status and therefore are more likely to have poor diet. But again, no definitive mechanism of what part of this being black, Asian, or Hispanic that makes you more likely to have diabetes. And then age, which is a huge factor, is if you're over 45, your metabolism starts to slow down naturally, and then you're going to become less and less responsive to insulin as that process goes about, and then obviously that puts you at a higher risk of developing type 2 diabetes. And then lastly is genetics. And the problem with genetics is in that signal transduction pathway that we have for insulin, there are over 100 different gene products involved in that. So the inheritance pattern is not going to be, a linear looking thing. It's not going to be something that where you can track it like a dominant recessive relationship. It's going to be a polygenic inheritance pattern, and that makes things a little bit more difficult to isolate. So these are my sources cited. I only use these two. This one here is about using insulin therapy for type 2 diabetes, and this one here is about the detailed mechanism of hemoglobin glycosylation. And lastly, here is the concept map for everything that I just talked about.